now my pleasure and honor to introduce our guest speaker, Professor Bernard canaud. He has, of course, as you mentioned yesterday, have got more than 300 and a lot of prize, but I can say he's a scientist and a great man. Thank you very much.
Thank you, Ahmed, for this nice introduction. I don't want to say I'm very big, thank you. But still, so it's my pleasure to talk about a very, very difficult topic this morning, acid-base disorder in chronic disease patients. But this is certainly overlooked because you will see in a minute, it affects all the CKD patients on the life cycle. It's not only dialysis patients, but I will try to convince you that we have to do something about acidosis. So I put the disclosure yesterday. I don't want to move again on this disclosure. I'm part of this industry now. Okay. So the agenda today, I put 5 topics. One is a very basic one. What is acid-base physiology or physiopathology? You have to understand. What is the consequences of disorder, acid-base disorder in the CKD patient, not only on dialysis? And what could be the beneficial effect of correcting the metabolic acidosis? Benefits and risks is always the same in the target. So, what are the basics of acid-base? I put very simple slide. You know that we are looking for acid-base just on the pH, so it's easy. But you, of course, in dialysis patient, you don't want to make arterial blood control. You have to check what is the venous blood control, which is a little bit different, but still very close. So you have the pH value, and the normal value is close to 735 to 745, so the average is 77.4. This is the pH normal of the range. And if you convert that in hydrogen concentration, it's 40 nanomoles, so it's not 40 millimoles, but it's 40 nanomoles. So we have a very narrow target range to maintain the patient. On the left side, and of course, if you get less than 7.3, you get acidemia or acidemic, and if you get on the right side, more than 7.5, you get alkalemic. But you see, at the almost extreme, you get death. So you have to be careful, and this is very important for human being to be in this homeostatic status, like sodium, like potassium, like everything. pH or acid base is very important, and you will see in a minute what are the consequences in a dialysis patient. So now, are we in the human body, we correct and we try to keep this pH constant, and this is the target in the center. So we have 3 elements. One is a buffer, and you know that the buffer is a bicarbonate part of the game, but you have a lot of buffer, you will see in a minute. This is the first line of defense. So as soon as something is wrong with the generation of hydrogen, there is a buffer acting, and the main actress is a bicarbonate system. The next is, of course, the lungs. But the lungs is just to remove what we call volatile acid. So CO2 by the lungs, we can remove the CO2, but there is no way to eliminate hydrogen. We just remove CO2. And the last is the kidney. And the kidney, of course, is a more efficient system because it can eliminate hydrogen by the different way on your genesis and different things, but also can regenerate the bicarbonate, which is a buffer. So we have to play with the 3 elements. In the first line is, of course, buffer, the second line is the lungs, and the third is the kidney. And this is the normal physiology. Now, if we move on the kidney disease patient, and that's much more complex. We know that on the left you get, I would say, bicarbonate, which is part of the, I would say, anion system, and it's a nice way to maintain the bicarbonate concentration between 24 to 27 millimoles. And you know, if you look on the anion, I would say, way, we have the gap, which is close to 15 to 17. So we have a nice way to make assessment about acid base, just based on the bicarbonate concentration. We don't need to have arterial gas to make this assessment, but still we have to look on the bicarbonate sodium, chloride, bicarbonate, potassium to make this calculation of the ion gap. This is the important one. As soon as the kidney is not anymore functioning, and this is the case in chronic kidney disease, we don't have any capacity to remove the hydrogen, we don't have any capacity to regenerate the bicarbonate. And of course, the only way to survive is just to remove CO2, but the CO2 is quite limited. So what the CKD patients are doing? They are taking this bicarbonate from the different buffer system, erythrocyte, phosphorus control and everything, but mainly from the bowel. So as soon as you get acidotic, if you want to maintain, I would say, your bicarbonate concentration, the body from the CKD patient are taking the bicarbonate from the bone. And we have a lot of amount of bicarbonate based on calcium carbonate. So at the end, acidotic status is affecting also this bone disease in the CKD patient. This is the way to preserve this equilibrium in the CKD patient. Sorry, it does not work anymore. So now we move to the CKD patient, and I will show you in a minute what is the point. Now, if we look from the left to the right, this is a CKD patient with a different stage, and you see over the time that the bicarbonate is decreasing. It's following the GFR decline. So at the end, you will see in a minute, almost, I would say, 90% of the patient after the stage 3B should be acidotic in some way. And now when you transfer the patient to dialysis, EMO on the top, or PD on the bottom part, you see that now we move from acidotic status to alkalotic status. And this is a completely, I would say, unphysiologic status, so we move from acidotic stage to alkalotic state after the session. It's not really good for the patient, and yesterday was a nice presentation about neurologic disorder of the patient. This very rapid change from acidotic to alkalotic is part of this disequilibrium syndrome affecting the brain of the patient. So you have to know that. PD is a little bit more stable. Of course, over the time, you don't have such large fluctuation of acidotic to alkalotic. Now, if the patient is transplanted, of course, you correct his bicarbonate. But again, when the transplant is failing, you see that the bicarbonate concentration is decreasing. So you have to keep in mind that the patient from the stage CKD to dialysis transplantation, there is a completely different profile, and you have to understand that it's not good for the physiologic status of the patient. Now, moving back to the chronic metabolic disease. Chronic metabolic acidosis, and you know that there is a lot of consequences. Is of course bone disease in the kids, and it was nice to show the presentation yesterday. Acidotic status is part of the growth retardation. So if you don't correct acidosis in the kids, there is no way to grow. There is a sort of glucose intolerance, so you can get a sort of insulin resistant. And I'm interested, and you will be interested, to the acceleration of progression of kidney disease. So now there is a lot of proofs showing that chronic metabolic acidosis is part of the game in the progression of kidney disease. It's of course affecting the muscle, it's affecting albumin synthesis, it's affecting the production of beta-2. So this is just a summary of what acidosis is doing in the kidney disease patient. So why keeping this acidosis there? And just concentrate on one aspect, which is the more interesting one. You know that in the cell mitochondrium, we have what we call ubiquitin proteasome pathway. And this is a fantastic, I would say, factory to recycle protein and to create, I would say, from protein, from hormone, to create some new amino acid. But acidemia and large, I would say, huge amount of hydrogen concentration are activating this proteasome system. So by the acidemic status, you are activating this proteasome or ubiquitin proteasome pathway, meaning that you create a catabolic state of the patient. I just show some elements. This is not in human, but this is a cows, so it's a sort of, I would say, animal experiment. But if you create acidotic state in the cows, you see immediately that you increase expression of ubiquitin or some subunit of the ubiquitin. So that means if you activate the acidotic status and you activate proteasome based on ubiquitin or different component, it's just proving that the acidotic state increased ubiquitin proteasome action and creates some, I would say, catabolic state for the patient. Now, if you integrate all these elements, acidotic status activate ubiquitin. It has some impact on the protein balance changes. This is sort of hypercatabolic state, activating hormone changes, activating inflammation, reducing the muscle power, and also has some activity on the renin-angiotensin system. So altogether, at the end, we know that acidotic state is affecting uremic sarcopenia. So it's not only the muscle which are affected, but certainly there is a way to catabolize other muscle. So why keeping this acidotic when we know that there is a lot of interaction, and also the acidotic state amplifying the action of the inflammation or amplifying the action of renin-angiotensin. So we have to play with this acidotic state. So now, moving to the correction now of the metabolic acidosis in different status. So I will start by non-dialysis patient, dialysis, and PD patient. So non-dialysis patient is interesting, and the point is, of course, to understand what is the impact. This is non-CKD patient. This is an NHANES study. You know, this is a sort of US way of testing the population in US every 5 years at this time, national nutritional examination. And in one of the last analysis, 2013, they look on the impact of bicarbonate. And if you look on this normal population, you see immediately that the population who get alkalotic or acidotic get the worst, I would say, survival profile. So meaning that if you are not really in the target of 20, 22, 25, if you are lower or if you are higher, you get, I would say, worst survival. So acidotic or alkalotic state affects the survival of normal population. Now, if you go in the detail and you check two subgroups of this population, non-CKD patient, and you see immediately that the bicarbonate by wild types, there is no, obviously, significant difference. Still, acidotic is affecting the survival, but this is not significant. Now, if you look on the subpopulation, which is the CKD subgroup, you see immediately that the mortality with the bicarbonate, which is less than 22 millimoles per liter, is increasing the mortality by a factor of 2.5. So, clearly that acidotic, I would say consequence, acidotic status is affecting the mortality of the CKD patient. So, in a normal, I would say, situation. So, this is one aspect. Now, two elements, and this is certainly what is new. This is a study which was performed, the first one in 2009, but there are a lot of evidence now, and that was the first study showing that metabolic acidosis has something to do with the kidney disease progression. So they make in the US a randomized study, CKD stage 3B. They randomized the population in two groups. Patient who was supplemented by a bicarbonate, oral bicarbonate. You see the dosage is 188 grams per day, which is quite limited. And they compare to the standard therapy, which is not supplemented. So it's just very simple randomized study, supplementing or not supplementing with bicarbonate. And what happened? And what happened is, of course, very clear. First, if you supplement the patient with bicarbonate, you increase your bicarbonate concentration, and you see that they move from 20 millimoles to about 24 millimoles per liter. So it's an increase by 4 millimoles. And what's happened on the creatinine clearance or GFR, you see immediately that the patient who get supplemented in bicarbonate, there is an improvement on the kidney disease. So, at the end, just correcting the acidosis prevents the kidney disease progression. Is it true? And of course, several studies were performed in the same way. I don't want to go into detail, but all the studies go in the same direction. Supplementation of bicarbonate is associated with a reduction of both CKD progression and mortality, all-cause mortality, and even cardiovascular mortality. So why not supplementing the patient with bicarbonate? Easy, very cheap, and it's not complex. And if you are not convinced, go to this, I would say, website, and you see that at least there are 3 trials running, clinical trial. So that means, again, there is a 3 study running to evaluate on the randomized evidence-based medicine, as mentioned yesterday, what is the role of correcting bicarbonate with different, I would say, target, less than 21 or between 20 and 26 lower. The point is that, of course, there are a lot of evidence that maybe we have to correct this bicarbonate. And why the acidotic states work on the kidney disease? I took this from Prof course, if you want to increase the elimination of hydrogen by the failed kidneys, this is a stimulation of the endothelin. And if you stimulate the endothelin, you have some, I would say, some consequences not only on the pressure, but you see you can have some interaction with the fibrosis. Now, if you want to increase just by this ammoniogenesis, also you have some activation of the complement. So you are integrating two elements. One is coming from the endothelin, and certainly the vascular effect on this intercellular fibrosis, complement activation, and you are also activating the aldosterone. And at the end, with the aldosterone, you activate certainly you promote glomerulosclerosis, and at the end, just by the acidotic status, you see that you are activating some of the kidney injury, and particularly the fibrosis. So this is a link between, I would say, mediators. I did not mention inflammation, but still is a part of the game. There is still activation by the inflammation. So, very simple receipt. You have to give to your patient, depending on the level of, I would say, kidney function, depending on the bicarbonate concentration, you have to supplement between 2 to 6 grams of bicarbonate a day, or maybe if you are a little bit afraid by the sodium that you weigh with the bicarbonate, maybe you have to put a little bit less with the citrate. But still you have to make this correction, and to target the bicarbonate, venous bicarbonate 20 to 25. Maybe you have to adjust the diabetic, because of course if you bring more sodium with the bicarbonate, you have to increase the diabetics, but still, it's easy and very efficient. So the second element is of course dialysis patient, and the story is a little bit different. Back to the basics. When you are doing dialysis, hemodialysis, hemodiaphytic, any form of, I would say, dialysis, the idea is of course to remove a lot of rheomic substances, also to remove organic acid and to remove some hydrogen which are associated with organic acid, and to bring back to the patient some bicarbonate. Usually you bring about 100, 150 millimole of bicarbonate during dialysis. But this is clear, with the dialysis you have to remove some fixed acid and to bring back to the patient to regenerate the bicarbonate for the patient. And this is why the profile of the patient is a little bit around 7. You have some acidotic state, and at the end of the session you are alkalic, and back to the session. Between the interdialytic period, the patient is regenerating hydrogen based on the protein intake and a lot of catabolism in the body, but still you have to look at what is the time average concentration of the bicarbonate to make sure that you are in the target range 20-22 degrees centigrade. So now, how it works in dialysis, and that would be nice to understand. When you do dialysis, of course, now with the bicarbonate dialysis, I would say 90% of the bicarbonate that you bring to the patient is linked to the bicarbonate. But you have to understand that depending on this acid, which is part of the acid concentrate, sometimes you get acetate, sometimes you get citric acid, or maybe chloric acid, depending, but the majority of cases is acetate. And this acetate is still metabolized by the Krebs cycle and provide bicarbonate. So at the end, what you are looking is what we call total buffer system. Bicarbonate, bring by the bicarbonate concentrate, plus the amount which is linked to the acetate. When you bring the bicarbonate to the patient, that's a different story. You have to fill what we call apparent bicarbonate space. We don't know what is the bicarbonate space, because at the end, the calculation is close to 40% of the body weight, just to make an assumption, because the difficulty with the bicarbonate is, of course, filling the patient, but immediately going to the bone. So there is a sort of distribution which is not clear, but if you want to make an assumption about what is the amount of bicarbonate that you need to bring to your patient, take 40% of the body weight, and you are not far from the reality. But you have to understand, it's not only the bicarbonate, but also the fraction coming by the acetate is part of the game to understand what is the kinetic of the bicarbonate. This is a text from Spalding, just to show you. When you do it bicarbonate hemodialysis, and this is 4 hours, of course there is a correction of the bicarbonate, and you see from the starting point 24, you gain up to 30 millimoles. But if you follow the patient at the end of the session, there is a sort of rebound or sort of overshooting of the bicarbonate, depending on the concentration of acetate. If you are using 4 millimole, which is standard. Usually your bicarbonate is increasing by 2 or 3 millimole at the end of the session. Now, if you increase by 6 or 7, 8 millimole, the acetate, you have to be very careful because it can have a little bit more. But still, bicarbonate is not stopping at the end of the session. You have to understand there is this sort of overshooting after the session due to this bicarbonate risk, which is generated by acetate or some acid. Now, if you look on the population, and this is some, I would say, huge, large numbers of patients, this is the Gaussian distribution of the bicarbonate pre-lysis, and you see that even if you get 23 millimoles per liter, you have a quite, I would say, significant percentage of patients who are still acidotic, and you have to be careful because you have a significant percentage of patients who are alkalotic. So that means in terms of bicarbonate, what you want is of course to get the average close to 20 millimole or 23, to bring the patient at the end of the session 29, but you have to be very careful in this case to make sure that at the end you don't put the patient on the alkalotic state, because this is dangerous for the patient. Alkalotic status is affecting cardiovascular, is affecting cardiovascular risk, and particularly based on arrhythmic state. Because as soon as you play with the bicarbonate, there is some, I would say, change for the potassium, for the calcium, for the magnesium, and altogether you can affect this with homogeneity of the organ. So the idea is to narrow this distribution curve of the bicarbonate to make sure at the end the majority of patients are between 20, 25 and no more. And if you observe that some patients are alkalotic before the session, you have certainly to reduce the bicarbonate concentration of your lysate. And again, back to the discussion yesterday, you have to personalize the concentration of bicarbonate to your patient. Sorry. This is what are the impact of this bicarbonate in the patient, and what are the practices today. So this is coming from the DOPS, 2004 from Bonner. If you look at the bicarbonate, this is the bicarbonate pre-lysis. And you see, according to the country, of course, you have, for example, in France, we are 29 or 24. If you are in Germany, 23. But at the end, you see, majority of patients are close to 22, 23 millimoles of bicarbonate. This is nice, but this is just an average. As I showed you a few minutes ago, remember this Gaussian distribution. That means you get about 10% in the acidotic state and maybe 10% in the alkalotic state. What is the consequences for